Welcome everybody to this webinar looking at the mechanical breath magic. How can we ventilate a patient with acute respiratory distress syndrome and both oxygenate and ventilate this patient without causing a secondary ventilator-induced lung injury? And the second part of the talk will feature, will whatever this magical breath is, will it also work for COVID-19 induced ARDS? As you can see from the photo here that my laboratory looks much more like one of your ICU units than it does a standard pipetting or molecular lab. That's because what we do in the lab is we have designed multiple sophisticated animal models that are both clinically applicable and translational. And what I mean by translational is anything that we find, any treatment that we find efficacious in these animals will likely be able to be translated very quickly into the clinical world. In other words, if we find a ventilation strategy that is effective, it'll quite likely work in human ARDS patients also. I have my email address down at the bottom here, and if I can help any of you with the basic science of ARDS, pathophysiology, or protective ventilation, please feel free to contact me, and I'll help you in any way I can. I have a lot to present this morning, so I'm going to go in a rather hurry, but again, contact me with any questions at the end of the show. So what's the magic? And I guess I think I'm hopefully a better scientist than I am a magician, because I'm going to actually tell you what the magic is right off the bat. And the magic is science. In order to design an effective, innovative, protective mechanical ventilation strategy, we first have to know the pathophysiology of the disease we're treating. So until we understand that, get that basic science in front of us, we aren't going to be able to scientifically deduce a ventilation strategy. In particular, what my lab looks at is the pathophysiology of the in the microenvironment, in alveoli and alveolar ducts. We have to know what the dynamic, how the normal lung inflates and deflates, and then how acute lung injury alters these normal mechanics and makes the lung so susceptible to a secondary ARDS. We're going to take a step back now and sort of look at where are we in protective mechanical ventilation. In other words, what is the current standard of care, low tidal volume? How effective is it at reducing ARDS mortality? And as you know, this paper was published in 2000 New England Journal of Medicine, in which they showed that a tidal volume of 6 cc's per kilo had a 31% mortality, and a tidal volume of 12 had almost a 40% mortality. So in the year 2000, we demonstrated that low tidal volume became the standard of care to treat patients with ARDS. But a lot can happen in 20 years, and sometimes what happens is good and sometimes not so good. So where do we stand 20 years after the implementation of the low tidal volume ARDS-NET study? And if you make a graph of ARDS mortality 2000 and 2020, in 2000, of course, we had the ARMA study, 31% mortality, and unfortunately, almost all meta-analyses, in which there are at least a dozen, currently show that the mortality of ARDS is 40% or greater. And you would think in the last 20 years we should have a mortality of less than 31%, but unfortunately that is not the case. So what do we use in our current strategy to try to prevent ventilator-induced lung injury? Currently we use really 4 components. We use low tidal volume, low plateau pressure, an arbitrarily set PEEP on an FiO2 PO2 scale, and recruitment maneuvers. And over the past 20 years, we have shown that tried every combination of tidal volume, plateau pressure, recruitment maneuvers, and PEEP in order to attempt to reduce mortality. And as you can see, the meta-analysis currently suggests that this hasn't occurred. And one of the definitions of insanity is doing the same thing over and over again and expecting different results. So what is the current hypothesis of ARDS pathophysiology, the one that suggests the low tidal volume? That ARDS is a heterogeneous lung injury where there's a small volume of normal tissue in the non-dependent regions, and this is affectionately termed the baby lung. And then there's a large amount of collapsed, unstable, and edema-filled tissue in the dependent lung region. So this is the current concept of ARDS pathophysiology. So if this is correct, why hasn't the ARDSNet protocol further reduced mortality? So again, we got to stop and think. If you're going to solve a problem, you have to understand the problem before you can come up with a solution. So that's what we're going to do today, is try to identify what the problem is and then identify the ventilation strategy to treat it. So first question, what if this 2-compartment baby lung model is not the pathophysiology that drives VILI? If that's the case, then the ARDSNet low tidal volume protocol is designed for the wrong disease. So this is the current pathology in a nutshell. We have a patient's lung. The dependent portions are the acutely injured tissue, edema, atelectasis, and low compliance. And the non-dependent is the normal or the baby lung. So if we take a normal tidal volume, normal size tidal volume, and try to push it into this lung with all this reduced volume, we're going to overdistend the normal tissue. And this overdistension of normal tissue is the current concept of ventilator-induced lung injury. And so that's what the low tidal volume, low plateau pressure attempts to avoid. However, evidence suggests that overdistension of this normal tissue may not be the primary mechanism of VILI. There are many publications, and again, for time, I'm just going to show you one of the publications from our laboratory, in which we had 2 groups of animals targeted with a heterogeneous lung injury to simulate human ARDS. And we overdistended both these groups. We had a high plateau pressure in one group with a high dynamic strain, a high tidal volume with each breath, and a second group also with a high plateau pressure, but this time with a low dynamic strain. So this is a pig lung, and what we did with the bronchoscope, we injured using a detergent just the dependent portions of the lobe, just like the patient. And so we had the acutely injured lung tissue in the dependent regions, and we also had normal tissue, which is the baby lung. And then we tested our ventilation strategy to see if it was protective of the normal tissue, the acutely lung injured tissue, neither or both. And this is what we found. So we had a plateau pressure of 40 in both groups, and as we know, the cutoff for safe plateau pressures is believed to be 30. So we were 10 centimeters of water over that. And in the low dynamic strain, where we had a small tidal volume and a small change in volume with each breath, there was no further damage to either the acutely injured tissue or the baby lung. And you can also see this on the cut surface. However, with a high plateau pressure and high dynamic strain, a large tidal volume, we see exacerbation of injury in both the acutely injured areas and in the normal baby lung, and we also see this on the cut surface. So the conclusion of this is, and many other studies, is that overdistension of the baby lung alone is not the sole mechanism of ventilator-induced lung injury. So what are the new concepts of VILI mechanisms? It's really regional lung strain, and by regional lung strain, this occurs not just in the dependent portions, it occurs throughout the entire lung. And the reason that it hasn't been identified is that previously the imaging techniques and the CT scans and the x-rays were not sufficiently detailed enough to see these small areas of regional strain. And in these regional areas of lung strain, alveolar are unstable, R&D, de-recruitment of each breath, and there are what is known as stress multipliers. And a stress multiplier occurs when you have collapsed edematous or unstable tissue with normal tissue surrounding it. And I'm going to get into detail on what I mean by both of these VILI mechanisms. So what knowledge do we need to reduce ventilator-induced lung injury? We're going to be thinking about the problem. Well, first we have to know what normal dynamic alveolar inflation and deflation mechanics are. We then have to understand how ARDS renders these normal mechanics injurious and thus makes the lung susceptible to a secondary VILI. Using this knowledge of both normal and abnormal alveolar mechanics, we need to design a mechanical breath profile to reduce or eliminate VILI. And by mechanical breath profile, that what I mean is all airway pressures, volumes, rates, flows, and the time that they are applied during inspiration and expiration. So let's look at the first mechanism, alveolar instability or recruitment derecruitment. So what does instability look like? And this is from our laboratory, and it's a subpleural, these are subpleural alveoli, and you can see with each breath, the alveoli pop open and collapse. And if you can think of a paper clip that's bent back and forth a dozen times and breaks, that's the same thing that's occurring to these alveolar walls. So this you're actually viewing ventilator-induced lung injury in a living lung due to alveolar instability. And what we have to do with our mechanical breath is prevent this from occurring. To model this, we use hexagons, and we collapse the center of the hexagons to simulate this recruitment derecruitment. So you can see in the center, this would be like the paper clip bending back and forth. But notice, since alveoli share walls, that as the center alveoli collapse, it drags and distends the adjacent alveoli. And this is what we mean by those stress multipliers. So let's get into the stress multiplier concept a little more depth. And I think it can be easily seen just from an engineering slide. Here we have a board, and we're going to pull on the board in two directions and measure the force or the stress that it takes to break this board. You can see there are lines of force that go through the board, and since there's no defect, the lines of force are equal and parallel. But look what happens if we put a defect in the board. What happens to the lines of force? They become concentrated, and there's surely no doubt in this board on the far right where that board is going to break. Same thing occurs in lung tissue. So here we have, again, our alveoli are simulated with hexagons. If you have homogeneous inflation, the lines of stress are equally separated throughout the entire lung. Now, if we have a defect, you see we have some collapse or instability or atelectasis right here. The lines of force are focused, and this is where the tissue trauma is going to occur. Again, they're termed as stress multipliers. This is an animation of a stress multiplier. Again, this is edema or collapsed tissue, and with every breath, you can see how the tissue surrounding that is distorted. And so we're multiplying the forces of mechanical ventilation in the normal tissue surrounding these stress multipliers. So how are we going to use this knowledge? Now that we're starting to gain some biological knowledge, how are we going to use this in order to reduce ventilator-induced lung injury? Well, of course, all we have to do is eliminate alveolar instability and stress multipliers, if these indeed are the two major problems or mechanisms of VILI. And then we will be able to either significantly reduce or eliminate problems with the ventilator. So the current strategy, again, uses tidal volume, plateau plus recruit maneuvers and PEEP in order to protect and rest and stabilize the lung. But as I showed you, the mortality has not further reduced. So what's missing? These are really the major components of a mechanical breath. We must be missing something, and I think what we're missing is the component of time. The time that we spend at inspiration and the time the mechanical breath spends at expiration. Our group has shown that using extended time at inspiration, a very short time at expiration, to be a superior lung protective strategy as compared to low tidal volumes and PEEPs. Because it reduces both regional instability and stress multipliers. So essentially, what this time-dependent adaptive breath does is that it opens up all of the tissue and then it keeps it open. So in doing this, you remove all the stress concentrators and you stabilize the alveoli, and therefore VILI is markedly reduced. So the second thing that we have we come to understand is that lung tissue, alveoli and alveolar ducts, inflate and deflate as a viscoelastic system. I'm going to go into some detail here because understanding viscoelasticity is critical when you design a protective mechanical breath. The engineers teach viscoelasticity using a spring and dash pot model. So here we have a spring connected to a dash in a pot, and the pot is filled with some kind of a viscous fluid. The force is the red T that's pulling on the spring, and the force in our case it would be the tidal volume. So we can see that there's sort of two components. The spring is rapid strain, and all I mean by strain is movement, change in size, change in volume. And the dash in the pot is the slow strain. So when you apply the force, the tidal volume, there's initially rapid change in alveolar and alveolar duct size, followed by a much slower opening and closing. And it's this viscoelastic concept that we can use to design our mechanical breath in order to protect the lung. And again, it's their time lag between the time the force is applied and the lung recruits, and a time lag from when the force is removed or the patient exhales and the lung begins to collapse. And that's sort of the trick that we're going to use in order to open and stabilize the lung. And we've developed the time-controlled adaptive, or TCAV method, that sets and adjusts the airway pressure release ventilation mode, or the APRV mode. And the reason we sort of came up with this name is because we found that the APRV mode is highly effective in opening and protecting the lung, but it must be applied correctly. And there's many, many ways to set APRV. And so our group has come up with this very specific way to set and adjust APRV, and we call it the TCAV method, time-controlled adaptive ventilation. So it's just a TCAV, it's just the APRV mode, but it's set precisely with what we find in our laboratory to be most effective. So this is a typical TCAV breath, pressure and flow over time. And you can see we have a very long time, or T high, at inspiration, or we call this the CPAP phase. And we have a very short time, or T low, at expiration, which is the release phase. So again, with the viscoelastic concept, we're going to have a long inspiration to recruit alveoli and a short expiration to prevent their de-recruitment. So here we have a spring and dash pot, and now we're going to inflate the lung and we're going to hold it. And look what happens. So we inflate the lung and hold it, and so we're in this part of the curve. And as you see, we inflate, and we're getting recruitment during that whole time period. So as we inflate, we get a first rapid inflation, and then we get a further inflation, and finally more alveoli recruited. So what we're getting is a continual recruitment over the entire 4 or 5 seconds that we hold this breath open. Now these are sort of the biological evidence. These are rat lungs with ARDS. You can see the atelectasis in dark red and the healthy tissue, open tissue, in pink. And we're going to set this lung with a 1 second inspiratory hold, typical of a conventional mechanical ventilation breath, and this with a TCAV breath with a 5 second hold. And you can see within 1 second, there's no red turning to pink, but if we hold this breath for 5 seconds, same pressure, the only thing difference is the time that the pressure is applied. We can see that the lung continually opens up over that 5 seconds. And that's why having this extended time at inspiration is so important to getting this lungs open and removing those stress multipliers. How about expiration? So here in expiration, this is in the T low on the left portion, and notice what happens. We have a very, very short expiration. There is some loss of volume in the spring, but notice that our dash pot does not have time to move. So essentially, we trick the alveoli to staying open by just now giving them enough time to collapse. And if we look at the curve on the right, if we have a very short expiratory time, we prevent all of that continual de-recruitment at the end expiratory pressure. Here's the biological evidence for this. You can see here we have a very long expiratory time, and you can see the alveoli are opening and collapsing with each breath. Here, all we did is shorten the expiratory duration and stabilize the alveoli. So this shows that all we have to do is to shorten that expiratory time, and alveoli will become stable. And again, to summarize, in inspiration, we continually recruit alveoli over the 5 seconds. So over a period of 6 or 12 or 24 hours, we can gradually nudge a patient's lung fully open. In very short expiratory duration or time, it just simply does not give alveoli time to collapse. And at the same expiratory pressure, if you hold it for 4 or 5 seconds, then you will begin to get extensive alveolar collapsing. So again, we're using the component of time along with pressures and volumes in order to trick the lung to be open and to stay open. So again, now sort of accumulating our thoughts on the problem. we found that ARDS mortality remains unacceptably high, that low tidal volume peat recruit maneuver have not further reduced mortality in the 20 years since they were implemented following the ARMA study in 2000. The mechanisms of VILI are alveolar instability, recruitment, de-recruitment, and these stress multipliers, not overdistension of the baby lung. Alveoli inflate and deflate as a viscoelastic system, and therefore we can use the mechanical breath profile component of time in order to inflate and stabilize this lung tissue. ARDS makes the lung time and pressure dependent. And what I mean by time and pressure dependent is that the lung will collapse in a very short period of time at atmospheric pressure. So what are we going to do? How are we going to prevent that from occurring? If we use a long inspiratory time and a short expiratory time, essentially our mechanical breath will be like putting a cast within a broken lung, and we'll stabilize it like putting a cast on a broken bone. So what we will do is we will hold the lung open using our time-controlled adaptive ventilation strategy until the lung heals, and then we will gradually reduce the time and pressure when the lung is no longer time and pressure dependent, and extubate the patient. So this is the problem, and with this scientific knowledge, I think we can go ahead and look at protective ventilation strategies in order to target these problems. So I'm going to show you the efficacy studies from my laboratory using the TCAV method. We often just, in these figures, because they're from our publications, we'll just say APRV, but in every single one of our studies, APRV was set using the TCAV method. This is a study by Dr. Roy, in which he had an ARDS-NET group, which had a tidal volume of 7 or 6 as per protocol, and a TCAV group in which the tidal volume ended up to be 12 cc's per kilo. In TCAV, we don't set the tidal volume, but we do measure it. This is our curve, our data curve from the publication. Time in hours, it's a 48-hour study, so the pigs are studied for 48 hours as they develop ARDS, and tidal volume on the y-axis. Two groups, a late low tidal volume, early low tidal volume, and an APRV set with the TCAV method. So now we have started in all groups with a tidal volume of 10 cc's per kilo. This gradually went up as the lung and the chest wall recruited to around 12 cc's per kilo in the APRV TCAV group. And of course, by rule, by protocol, they were 6. Both the low tidal volumes were set at 6. So how did this high tidal volume affect driving pressures? Everyone's worried about these days. We have a non-protective group in which we gave tidal volume of 10, APRV TCAV group, which ended up with a tidal volume of 12, and the low tidal volume of 6. We started out with a driving pressure of 10, which, as you know, is the normal range. And then in the TCAV group, the driving pressure stayed in the normal range throughout the entire 48-hour study. Whereas with non-protective ventilation, with the tidal volume of 10 cc's, we had a very, very high driving pressure of around 40. With low tidal volume at 6 cc's, driving pressure is around 25. And with the 12, it's down around 10 or lower. So how can this be? How can we have a high tidal volume and a low driving pressure? It's because driving pressure is calculated as tidal volume divided by respiratory system compliance. And because the TCAV method is such an effective recruiting tool, the lung will remain totally open and the compliance will stay very high. And so therefore, if the compliance stays high, you can have a larger tidal volume and still have a low driving pressure. So what was the compliance in Dr. Roy's study? Again, time, here's compliance. Compliance started around 30, and for a 30 kilogram pig, compliance of 30 is normal. Late, early, and APRV, and you can see in the APRV TCAV group, the compliance stayed almost normal for 48 hours. And with the tidal volume of 12 and the tidal volume of 6, our tidal volume was dramatically reduced into the range of around 10 milliliters per centimeter water at the end of 48 hours in both low tidal volume groups. Now, this is sort of the take-home picture. It's just the gross photo at 48 hours necropsy. On the left is the TCAV method, and on the right is the ARDS method. And as you can see, in the TCAV method, our lung stays uniform. It is not heterogeneously injured. but uniformly inflated, and you can see that on the cut surface. No stress risers or multipliers, no stress multipliers in this lung. Contrast this to the lung using the low tidal volume method, and we can see heterogeneous collapse and atelectasis along with normal tissue. We can see edema in both the airways and in the intravalvular spaces. And remember, this lung in this particular animal had a tidal volume of 12 and a driving pressure of 9. In this animal, tidal volume of 6, but a driving pressure of 27. To show that this is an extremely severe model, because we don't control source, we let the septic, it's a fecal clot, stay in the animal for 48 hours. So they become very septic in the third space, much worse than most patients. These animals can be as high as 60 liters positive, and even with a 60-liter positive patient, we can pull out a pristine lung. And we published 3 studies using this model and showed the same thing in all 3 studies. So a very, very powerful tool to keep the lung open, inflated, and keep edema out. We do have one statistical study demonstrating that TCAV will indeed works in patients. And this was published by Penny Andrews in Journal of Trauma and Acute Care Surgery 2013. And what she did is she compared 15 other surgical intensive care unit SICUs to their SICU and looked at the ISS, the injury score, looked at the percent of patients that developed ARDS, and looked at the in-house mortality associated with ARDS. The bar and whiskers are from the 15 other SICUs, and the little black dot is from the Maryland shock trauma in which these patients were put on TCAV as soon as they were intubated. So as you can see, the ISS score at the shock trauma, they were in the higher range, so that these patients were at least as sick, if not sicker, than in the other 15 ICUs or SICUs. Percent ARDS, almost off-scale low. In the 15 SICUs, it was a 14% ARDS percent and only 1.3% in Maryland shock trauma. Mortality, percentage-wise, again, almost off-scale on the low end, 14.1% versus 3.6%, and none of these patients died with respiratory failure. They all had good gases, and they died of other problems. So now if we look at, in the same study, the lung injury prediction point score, or LIPS, and the percent of ARDS or ALI on the y-axis. In the study I just showed you, the LIPS score was 8.7. At 8.7, we should have percent ARDS of 35%. And as this showed you, they had a 1.3% using TCAV. So we're really switching the decimal points. We're not just a subtle improvement, it is a dramatic improvement, a dramatic reduction in incidence and mortality of ARDS when ARDS is used using the TCAV method and it's applied early. These are some more clinical data. They're just individual case reports recently published in one of our review papers to show how adaptive tidal volume, respiratory system compliance, and driving pressure is in patients. And these are brain dead lung donors in which we put TCAV on in order to recruit and stabilize the lung before transplant. So here we start with TCAV at 0 hours, so that the patient has just been converted from conventional to TCAV, and there's a great deal of collapse. And then as we go for 12 hours and 24 hours, the collapse is ultimately nudged out of the lung using TCAV until we get a fully inflated lung. So let's look at the data. The tidal volume in when they first went on TCAV was 7.3. It gradually rose to 9.2, and at 24 hours it was 10.1. So how did that compare with driving pressure and compliance? When we first put the patient on a TCAV, their driving pressure was 16 because their compliance was so low. It was at 27. But notice that our 7.3 milliliters per kilo, it's almost down there to the low tidal volume method. So you're never going to be delivering a high tidal volume into a low compliant lung using the TCAV method because it's just CPAP. As the lung recruited, driving pressure went down because compliance went up, as so did tidal volume. And after 24 hours, we got the entire lung open. Driving pressure is now normal, and compliance is 88. And tidal volume's gone up to 10.1. So here's a tidal volume of 10, and yet it's perfectly benign because the lung is open. So it's not just the size of the tidal volume, but the size of the lung you're blowing that tidal volume into. Here's a second brain dead donor on conventional ventilation. You can see the whited out x-rays, driving pressure is 26. 3 hours on TCAB, driving pressure has fallen to 17. You can see the lung is already starting to open in 3 hours. 29 hours, driving pressure is 14, and the chest x-ray is almost completely black now. And 84 hours, driving pressure is now 11, and you can see the fully open chest. Both these brain dead donors' lungs were successfully transplanted. This is another case study in one of our recent review papers, and this is TCAB for severe ARDS on ECMO. As you can see in the first photomicrograph, our lungs are totally whited out. Patient's been on low tidal volume ventilation using PCAC for 21 days and on ECMO for 15. PO2 59 and PF ratio 196. So 15 days go by. It's now 30 days on ECMO, 36 days on PCAC, and we're losing ground. The chest X-ray a little bit more open in the upper quadrant of the right lung, but still in pretty bad shape. Going on to TCAB for just 2 days, you can see that the chest X-ray is markedly improved. PO2 110, PF ratio 271. TCAB for 11 days, PO2 107, PF ratio 414. A patient was decannulated, extubated, and went home. So again, just a case study, not an RCT. But we get very, very dramatic results when APRV is set and adjusted using the TCAB method. So again, I mentioned this broken lung concept, and I think it's a really good concept to understand exactly what is going on with the TCAB method. As I mentioned, the acutely injured lung becomes time and pressure dependent. So if you just are ventilating yourself at room air, your lung is going to rapidly collapse. So all we do with TCAB is we cast this broken lung by putting a proper amount of pressure and time during inspiration and expiration. And so the lung is still injured. However, we have casted it in its open, natural, physiologic position. And then as the lung heals, we can start removing the cast and decreasing both the times and pressures. And in doing so, we will remove the mechanisms of VILI, which are this regional alveolar instability, recruitment, derecruitment, and stress multipliers, effectively eliminating ventilator-induced lung injury. So to summarize, lung parenchymal tissue changes size, which is termed strain, as a viscoelastic system. Thus, the longer time at inspiration will open more alveoli, and the short time at expiration simply won't give the lung enough time to collapse. We've demonstrated that our TCAB method, using the knowledge of this viscoelastic strain, is very effective at openizing and stabilizing acutely injured lung parenchymal tissue. The TCAB method is by far and away the most studied method to set the APRV mode. We find it both adaptive and personalized. Since the expiratory duration is set using the slope of the expiratory flow curve, and again, this is all spelled out in our review papers. It's adaptive, which is an assessment of the patient's compliance. It's adaptive to when the patient gets better or worse, and the tidal volume, as you saw, as the patient lungs open, the tidal volume will grow, but the diary pressure will actually go down. There's many other studies out there that have used APRV, and some have set APRV in very unphysiologic methods, and in doing so, these usually don't work anywhere near as well as set using the TCAB protocol. There's multiple studies from our laboratory have shown that the TCAB is both the mechanisms of TCAB and the efficacy in our large animal translational models. And as I just showed you, we have the one statistical analysis in humans and several case studies and review papers. So bottom line, can mechanical ventilation be used to reduce the VILI? We have found that our TCAV method is very effective in our patients, and that conventional methods don't work nearly as well. A sort of basic physiologic primer: bacterial, sepsis, pneumonia, hemorrhagic shock-induced ARDS. We have to ask ourselves the question, will the TCAV method be effective in patients with COVID-19? Again, what are we going to do? We have to look at the problem. And to look at the problem, we first have to look at the differences in the pathophysiology of COVID-induced ARDS or CARDS as compared to ARDS. So what we do know is that the endothelial cell is one of the main targets of the SARS-CoV-2 virus, and it enters through the endothelial cell through the ACE2 receptor. This leads to the cytokine storm, which causes a further injury and increase in permeability endothelial cells, and exposing the basement membrane of these endothelial cells will lead to thrombosis. So we have a little bit different pathophysiology right off the bat. Also, since the SARS-CoV-2 virus enters through the ACE2 receptor, it has a significant impact on the renin-angiotensin-aldosterone system. As you know, the RAS system has a big impact on sympathetic activity, on water retention, on aldosterone secretion, on arterial vasoconstriction, and on ADH secretion. And combined, all of these can have a significant impact on pulmonary vascular tone. Differing pathophysiology than standard bacterial sepsis, it seems that COVID-19 has two types: a type L, which has a low elastance, low ventilation perfusion ratio, low lung weight, and low lung recruitability, with the low ventilation perfusion hypothesized to be due to hypoxic pulmonary vasoconstriction. So in the type L, these patients' lungs look fairly normal. They have a pretty good compliance. They aren't edematous, and you don't see a lot of whiteout. However, they're still unable to oxygenate. In the type H, it's much more typical to bacterial ARDS. I have a high elastance, a high right to left shunt, a high lung weight, a lot of edema, and a high recruitability because there's a lot of collapse. And again, the edema is in the order seen from bacterial sepsis. So there are two phenotypes that we would have to deal with when trying to ventilate the COVID patient. Here's to show, again, highlighting this problem between the L and the H. The top is an L patient. You can see that the lung is almost totally open. In the type H, we have a lot of dependent collapse, very typical looking ARDS kind of lung. But look at the PF ratios, almost identical. So there's something really funky going on with COVID when it comes to the perfusion of the lung, because the ventilation can be very good. So the only thing I could explain these low PF ratios with an open lung is some kind of alteration in pulmonary perfusion. And so to summarize the pathophysiology, and again, this is still very early, but it's it is a peripheral diffuse alveolar damage, or DAD, with paravascular T-cell infiltration. We have severe endothelial injury disrupting the integrity of the vascular endothelium, causing coagulopathy and widespread thrombosis. We also have microcapillary thrombi and angiogenesis and growth of new vessels. So some of these are typical of sepsis-induced ARDS, and some are not. So here's a slide showing the alteration in microcirculation, in the systemic microcirculation, and there's a device that you can actually look at microcirculation in vivo under the tongue. And what they showed is that a patient with COVID that was very sick, had a PF ratio of 74 and a D dimer of over 6,000. You can see how the capillaries are sort of broken up and not perfusing, as compared to a patient with COVID and with a PF ratio of 247 and a D dimer of only 741. You see all the capillaries are fully perfused. So here's one direct evidence that COVID alters systemic perfusion. So what about pulmonary perfusion, which we need to worry about when we're ventilating these patients? And pulmonary perfusion is very strange in COVID patients. Here we see both ventilation and perfusion using a dual entry CT scan. So we see in A, we see there's a great deal of atelectasis in both the right and the left lobes. And strangely, there's also an increase in perfusion in these collapsed areas. So not just a perfusion, but an increase. So essentially the area of collapse in the COVID lung is being hyperperfused. So it's more than just the loss of HPV or hypopulmonary hypoxic vasoconstriction. Something else is going on. This is a highly abnormal finding. So can hyperperfusion of the non-aerated lung explain this COVID hypoxemia? Term for this early stage hypoxemia is called silent hypoxia because it's poor oxygenation with a relatively open lung. And Gattinoni has shown that in these patients, you can have a compliance of 50, a very good compliance, and yet a shunt of almost 50%. Really something unheard of in other forms of ARDS. They speculate impaired HPV, and a group headed by Jason Bates out of the University of Vermont built a computational model based on Dr. Gattinoni's data to see if hyperperfusion and loss of HPV could explain these high shunts with these relatively open lungs. And in this clinical model, or this computational model, they modeled the black is aerated and the gray is non-aerated. And here they also, this would be the upper part of the lung, the middle part of the lung, and the lower part of the lung. And then they had hypoxia, HPV is normal, hypoxic pulmonary vasoconstriction impaired and reversed. And you can see with normal HPV, you're going to get low perfusion in the non-aerated areas. If you lose it, if you lose HPV, it becomes impaired, then you get equal perfusion. Or if you get a vasodilation in these areas, you could actually get an increase in perfusion in the collapsed areas. So what they find? They found that the extreme shunts in Gattinoni's study could not be explained with the small amount of collapsed tissue unless there was hyperperfusion of the relatively small amount of collapsed tissue. This could be caused by vasodilation. The perfusion would actually have to increase by 3 times into the collapsed areas, and pulmonary embolisms could exacerbate it. So what they found using this computational model was not only is HPV impaired, it's actually reversed. And there's a hyperperfusion in these capillaries, which is confirmed by the dual energy CT. I threw this in actually just yesterday. It was just published a couple days ago in the Blue Book. And again, looking at pulmonary angioplasty secondary to severe COVID, and they found that the patients were hypercoagulable phenotype. They had a marked impairment of pulmonary perfusion, and pulmonary angioplasty and thrombosis were part of the problems. And what they showed using their CTs is what they called a vascular tree and bud. And it demonstrates that there's actually a vasodilation in the non-compliant collapsed areas. And again, a paper was just published, is just out yesterday. But again, another paper confirming this hyperperfusion in the collapsed lung for COVID patients. So in conclusion, SARS-CoV-2 enters the cell through the ACE2 receptor, which are embedded in endothelial cells. Therefore, it has a negative impact on the RAS system, which could alter pulmonary perfusion. Injury to the vasculature could expose the basement membrane and then lead to thrombosis and pulmonary embolisms. HPV could be inhibited by the death of the endothelial cells, since the endothelial cell and the smooth muscle work hand in glove in order to control HPV. And a computational model suggests that the only way to get the very high shunts that's seen in the clinical studies is to have a hyperperfusion of the collapsed tissue. And hyperperfusion has been seen using dual CT scans in patients with COVID-19. To summarize, so here we have an endothelial cell with an ACE2 receptor. The SARS-CoV-2 enters the cell and causes damage or death. This leads to loss of hypoxic pulmonary vasoconstriction function. It leads to pulmonary edema, causing surfactant deactivation, atelectasis, and alveolar instability, and also stress concentrators. Also causes pulmonary embolization with exposure to the basement membrane. Alterations of the RAS system becomes dysfunctional, and combined, they alter pulmonary perfusion such that you actually get a hyperperfusion in the collapsed areas, which is highly abnormal. So will TCAV work on CARDS patients? At this point, I just don't know. We surely have had some very successful cases at Upstate in which both the TCAV was used early and rapidly turned around a patient with H-type COVID, and used late in a patient that was just about to go on ECMO, but it spared her from ECMO and actually saved her life. But just not that many cases being done at Upstate using the TCAV method. It is personalized and adaptive, so it should work regardless if you put it on the L or the H type. But however, it will not fix the perfusion abnormality, as will any ventilator strategy, since the ventilation strategy is working on the air side, not the vascular side of the lung. I have attached these papers if you want to go back and look up some of our work. These are mechanistic TCAV papers. These are efficacy papers in our large animal laboratory, and these are recent reviews. With that said, if I have time, I will answer any questions. And again, feel free to contact me anytime, and I'll be happy to talk about the pathophysiology of ARDS, COVID, and protective mechanical ventilation. Thank you.